My name is Kenira Maroyi. On behalf of the team, I would like to talk about the etiology and factors associated with urogenital fistula among women who have undergone Cesarean section in the Democratic Republic of Congo. I declare no conflict of interest. The aim of this study was twofold: to describe characteristics of DRC women who developed urogenital fistula following C-section, to determine characteristics associated with two fistula etiology. In one hand, obstructed labor and C-section. We abstracted data from all the patients with urogenital fistula following Cesarean section who received care during an outreach surgical campaign in the north of DRC. Based on findings at the time of surgical fistula repair, urogenital fistula etiology was designated as either 1. Related to prolonged obstructed labor, or 2. Surgical complication of Cesarean section. Data were abstracted regarding patient age, parity, labor, duration of symptoms, and characteristic of fistula. Descriptive analysis characterized patients with urogenital fistula related to obstructed labor versus Cesarean section. Variables were included in the logistic regression models based upon biological plausibility. The median age of women was 32 for those whose fistula etiology was related to their C-section. Those whose fistula etiology was related to their obstructed labor had a median age of 30. Women who had a fistula developed at a younger age were more likely to have a fistula etiology of their obstructed labor, and those whose fistula was the result of a C-section had a significantly high parity compared to those whose fistula was the result of an obstructed labor. The women who had an obstructed labor that caused their fistula were more likely to attempt delivering their child before arriving at the hospital. As suspected, C-section was conducted on all fetus that were alive. Surprisingly, 88% of women had a C-section to extract their demise fetus. Women with a fistula attributed to C-section were significantly more likely to have a medical worker help during their labor. Thus, not surprisingly, women with a fistula attributed to a Cesarean section were more likely to start their labor at a hospital or a health center. Women whose fistula was related to having a Cesarean section were more likely to develop urine linkage delayed from delivery. Our findings show that the majority of fistula related to obstructed labor were repaired vaginally, while fistula related to Cesarean section were repaired abdominally. About factors associated with obstetric fistula, on univariate analysis, age and parity were associated with a decreased risk of obstetric fistula. At-term delivery prior to hospital arrival was associated with increased risk of an obstetric fistula on univariate and multivariate analysis. To conclude, in the DRC, C-section is commonly performed on women who arrive at the hospital following a prolonged obstructed labor and fetal demise. They are already at risk for urogenital fistula, and C-section increases the risk of complex fistula requiring abdominal approach to repair. We propose that fetal extraction rather than C-section should be performed to decrease additional morbidity in this population. Training obstetric providers and staff to access maternal status on arrival may prevent unnecessary cesarean section and decrease women's risk to complex urogenital fistula development. Thank you for your attention.